move on to our next session, and it is under academic grant of Jackson Paul. So this would be a topic of role of inositol in PCOS, and to present this is Dr. Kavita Agarwal, and we already have an introduction with us. So please, ma'am, enlighten us with this topic.
Thanks, Dr. Garima, for the kind introduction. I will just share the slide. So I'll be talking on inositols in PCOS. I will start with an overview to PCOS, followed by insulin resistance in PCOS, and then I would come on what is the role of inositols in PCOS, what is the actual benefit. So PCOS is seen in 6 to 8% of the reproductive age women. It is a complex condition with main 3 diagnostic features, that is hyperandrogenism, which the patient can present as hirsutism or acne, or chronic anovulation, the patient can present as oligomenorrhea or amenorrhea, and the polycystic ovaries by ultrasound. So if we go back to 1990, the NIH gave the criteria for diagnosis as hyperandrogenism and oligomenorrhea or amenorrhea. Then in 2003, Rotterdam said 2 out of any 3. And then Androgen Access Society in 2006 made hyperandrogenism as mandatory. So moving further, the basic what we want to know today is what is the clinical impact of this on PCOS? Why does the patient go to a doctor? That is either for the reproductive reason or it may be because of metabolic reason. So reproductive, it can be because of chronic anovulation leading to oligomenorrhea, infertility, or it can be metabolic leading to obesity, hyperandrogenism, hirsutism, acne, type 2 diabetes. As PCOS, in this, there is high risk of gestational diabetes, metabolic syndrome, cardiovascular diseases. So if we see in PCOS, it's basically targeted to the patient's primary complaint. If the patient is coming with irregular cycles, hyperandrogenism, we might be starting on OCPs, or if the patient is coming with infertility, we might be thinking of ovulation induction, IUI. But prevention and treatment of associated comorbidities go hand in hand. So the first line treatment in any of the conditions remains as diet and lifestyle changes. But if we see since more than 25 years, metformin is being used in PCOS for reducing the insulin resistance. So why is it that so? So for that, we will need to look into the insulin. What is insulin doing? So insulin, it regulates the blood glucose in 2 ways. It is promoting the glucose cell uptake. Now, this glucose can be used in the form of energy or it can be stored as glycogen. So in a normal cell, when the insulin is going to bind to the receptor and form the insulin receptor substrate complex, there's a release of secondary messengers which act, that is PI3 kinase, which will activate GLUT4, and then there will be uptake of glucose. Now this glucose can be used for energy or it can be stored as glycogen. Now these secondary messengers of insulin, they are made up of inositols. They are derived from inositols, which are 6-carbon sugar alcohols commonly found in fruits, grapefruit the highest, beans, almonds, and walnuts the highest. So, although inositols have 9 stereoisomers, today we will be talking about myoinositol and dichirioinositol because they serve as secondary messengers to insulin. So, myoinositol, it enables the insulin and FSH signal transduction in the ovary, whereas dichirioinositol is acting in the peripheral tissues. So it is required for insulin action in the peripheral tissues. And in the ovaries, if we see, it stimulates the testosterone production. So myoinositol is promoting the glucose cell uptake because it leads to the production and activation of this PI3 kinase, which will activate GLUT4 and will lead to the glucose cell uptake. So this is what the MI is doing the action. Whereas if we see DCI, it is acting in the peripheral tissues. There it is acting as second messenger. So it will be present in high concentrations in the glycogen storage tissues, that is liver, muscle, and fat. And it will be low in the tissue, needing elevated energy levels like ovary. So if there is one more thing which I would like to add here, that there is enzyme epimerase, which converts this MI to DCI, and this enzyme is also insulin dependent. So now in PCOS, if there is deficiency of inositols. And it has been seen in studies that in PCOS women, there is 5 times more urinary clearance of inositols. The plasma levels of inositols are very low, and there are high 24-hour urinary inositols. So if the deficiency occurs, now this PI3 kinase activity is going to decrease. The GLUT4 is not going to get activated, so the glucose is not going to come into the cell. Now, when the glucose is not going to come into cell, that is the role of MI is not being fulfilled. Also, the DCI, the glycogen synthesis, is not occurring. So finally, there is going to be hyperglycemia. And when the pancreas is going to get sensitized to this high blood glucose, it's going to release more insulin, which will lead to hyperinsulinemia. And this is leading to PCOS, what we see, the insulin resistance, which is a pathophysiological contributor in 50 to 80% of the PCOS women. So, and it is seen both in obese as well as the lean PCOS women. So this is what is happening in the blood, where there is hyperglycemia as the glucose uptake is not occurring. Also, DCI is not acting, so glycogen synthesis is not occurring. Now coming to the ovary, what is there? It is happening because of the inositols deficiency. So ovary, unlike other tissues, never show insulin resistance. Here, when there will be increased insulin, now the insulin sensitive epimerase enzyme will get triggered. Due to this triggering of epimerization, MI is going to get converted to DCI. So in the ovaries, although MI was doing FSH signal transduction and DCI was producing testosterone, but now what will happen? The DCI paradox. Here, in the overweight PCOS, high insulin level will increase the conversion of MI to DCI, and the normal physiological ratio of 40:1 will get disrupted. So in the ovaries, there will be increased DCI, which will promote androgen synthesis, and MI will be depleted, leading to worsening the energy state of oocytes. And finally, all these events together will impair the FSH signaling and oocyte quality. So in this way, both the reproductive and the metabolic effects will be seen. So now, coming to the main part of this talk, that is, could inositols be considered to treat PCOS? So if we date back around 1999, the first human trial was done in US, which used DCI alone. After that, they used higher and higher doses of DCI, but they did not found any improved results. So they stopped using this drug and stopped doing research on it. Finally, the ball was picked up by Europeans and they started doing research on it, but they used MI alone. And then when they found good results, they went on to using MI is to DCI combination. So if we date back in 2009, when the study was done, they found that use of MI for 3 months, the plasma LH, testosterone, free testosterone, insulin, HOMA-X index results in significantly reduced. Also, both hirsutism and acne decreased after 6 months of therapy. So if you see, there's a reduction in total testosterone, reduction in free testosterone. This is another study which again showed the same thing when they compared MI use along with placebo. Again, the MI gave good results. There was reduction in testosterone levels. Again, this is a study in 2013 where the folic acid was used as placebo. Again, a randomized controlled trial was done and it was seen that it gives us good result. Insulin sensitivity and HOMA index was significantly improved. Also, clinical pregnancy rate and delivery rates were compared to placebo and were found to be improved. So now, the next thing what they did, now they compared MI with metformin, as metformin was used since many ages. So they thought of comparing it. So in this study, when they compared, 120 women were randomly treated, and the results were that again, MI was found to give better results, although in this study, it was not statistically significant. Then this was another study, although done on only 60 subjects, but yes, the results were statistically significant. Now, this is a recent trial in 2019 with a systematic review and meta-analysis with a total of 355 patients. Here again, they did not found any much difference in the efficacy of metformin and myo-inositol, but they found myo-inositol to be better tolerable as metformin was reported to have much of gastritis. So they found it better tolerable, better acceptability of myo-inositol. Then in 2017, again, a meta-analysis and systematic review was done on 935 women, and they again found that myo-inositol supplement was associated with significantly improved clinical pregnancy rate, also the grade 1 embryos proportion and total amount of ovulation drugs were also improved in favor of myo-inositol. So now what the evidence has told us that MI is a good drug. It has been proved to be efficacious, but MI is to DCI, which ratio? The physiological ratio is 40:1. Now, what the evidence has to say about this ratio? So in 2012, when they compared MI plus DCI and it was compared with MI alone, the results were found to be better with MI plus DCI used in the ratio of 40:1, which showed significant improvement in plasma glucose and insulin compared to MI group. There was improvement in total testosterone and sex hormone binding globulin at 3 and 6 months. Although the combination studies have been done on a very small number of patients, this was also done on only 20 patients. It showed improvement, but the studies have been done in this study on only 46 women. Earlier, there were 20 women and then 40 women. So we are lacking in the research. Here, we are lacking in the number of studies, number of subjects. We don't have the big trials, but whatever trials have been done, have shown a good result. So this was a recent in 2019 where they compared various ratios now. MI is to DCI was given in various ratios, 20:1, 40:1, 80:1, and they found that 40:1 gave the best results. Although here again, there were only 8 patients for each group. The total were 56 PCOS patients who were given, but best results were found to be 40:1. So combined treatment in physiological ratio of 40:1 is able to restore both hormonal and metabolic parameters in overweight PCOS women earlier than myo-inositol alone. And hence the rationale of 40:1 if we go by pathophysiology or we go by the evidence. But before we accept any drug in our clinical practice, we need to know the safety concerns. So let's see what the evidence has to say about the safety concerns. So in the whatever studies have been done, myo-inositol has been found to be a well-tolerated and safe both in obese and lean PCOD patients. Side effects when present are mild and mainly gastrointestinal, nausea, flatus, diarrhea. It is not only safe in pregnancy, but it is beneficial. It has been found to reduce the chances of neural tube defects, improvement in gestational diabetes. And this was a recent study in 2019, RCT, which found that inositol supplementation was associated with lower rate of gestational diabetes and lower preterm delivery rates, and no adverse effects were reported. So the key points are MI and DCI. They both play a key role in insulin receptor signaling. The low level of MI adversely affects the ovarian function and egg quality. Elevated levels of DCI in ovary cause increased androgen production. And the supplementation of 40:1 ratio of MI is to DCI improves not only the metabolic endpoints, but also restores ovulation and improves fertility in the PCOS patients. Now, if we come on to the recommendations, Eshrey in 2008 said MI can be evaluated as the primary method of ovulation induction in PCOS women. ASRM in 2012 says that MI treatment should be routinely introduced in the IVF protocols. Now, coming to the recent international evidence-based guidelines for the assessment and management of polycystic ovarian syndrome 2018 says that inositol in any form should currently be considered as experimental therapy in PCOS with emerging evidence on efficacy, highlighting the need for further research. So definitely, there is a need for further research, but we should keep in mind that whatever evidence we have till date, maybe on a small number of samples, randomized trials, they all show safety and efficacy of MI plus DCI usage in the PCOS women in the ratio of 40:1. Thank you. Have a nice day.
Thank you, ma'am, for the excellent talk. So I request our chairpersons to give their expert comment.
I would just like to know that lifestyle modification, how far does it actually bring about a change in these levels of myoinositol and DCI?
Ma'am, it is said that even if there is 10% weight loss, and then also it will give significantly good results if there is even 10%.
So it affects both of them, both the levels.
Yes, definitely.
The therapeutic level that you recommend is 40:1.
Yeah, because that is the physiological ratio, and that is all even the evidence has shown. They have even
And that
used
is what we should aim for.
Yes, ma'am.
That is just the proportion of the two inositols.
Yeah.
But I think what Dr. Basu is saying, does lifestyle intervention, will it bring the same change as giving the inositols on blood level?
Not exactly. It is basically, there has been no comparative study that you are just giving a lifestyle management to a person.
Not comparatively, just lifestyle intervention. Will they bring the same change as giving inositols? That's the question. Has anybody looked at that? What does lifestyle intervention do in terms of objective evidence? Subjectively is okay. Objective evidence.
I don't think so.
So I think we need to look at that also,
Yeah.
Probably
definitely.
we keep on talking a lot about lifestyle modification, and I don't know how objectively. I was wondering, as Dr. Renu has just clarified, any studies which actually highlight whether there are any changes.
Because lifestyle.
Sorry.
Sorry, ma'am, can I interrupt?
No, carry on.
There are studies which have looked at the leptin levels, AMH levels, and even in the ovaries, they've looked at the levels of androgens when they've looked at lifestyle and modification and BMI. But I think Renu ma'am is very right. Nobody has looked at this aspect where you've compared this with the inositols. So I think all the studies that we've had is in isolation or in comparison to our traditional methods, for example, metformin. And only recently, we started having studies, even having a head-to-head comparison of the metformin to the inositols. So I think if you're looking at the 3-tier level, like you're saying, lifestyle, inositols, metformin, I think we're still awaiting that study. But individually, they have been assessed.
Because what I'm saying is that when you do lifestyle intervention, it is changing the body physiology in multiple ways. There's not one way. And when you talk about these drugs, whether it is metformin, any insulin sensitizer for that matter, it seems to be very simplistic. You give this medication and she will get pregnant. There are 101 factors, and how can you just have a cause and effect of just one drug?
We can't, ma'am, because it's multifactorial.
Yeah.
It's just like the etiology of PCOS. So is all the interventions. It's
as complicated as the etiology, so complicated is the management itself for everything, for that matter. I think.
Thank you. We conclude this session, and I'd like to thank all our speakers and chairperson. It was a brilliant session.